So again, my name is Arun Nagdev. I'm at Highland Hospital. The goal of this group think is really a group think to have more people involved in blocks once a month. Keep it 30 minutes. Don't make it long and painful. Make it fun, interactive, and people will eventually work together to build cool stuff. So I'm not going to go through this literature. I have all of it if you guys are interested. It's not vernal rating score, but verbal rating score. I put this talk together recently, but pain scores are subjective, and we all recognize this, right? Verbal rating scores, visual analog scores. There's a ton of bias in this, and there's a lot of literature. So one of the interns on this month, we published a case of doing a block in a 60-year-old lady with cancer pain who came in with abdominal mets, came in for more pain control. And so we did an electrospinning, and she felt so comfortable she wanted to go home. And then she was followed up with an oncologist next morning. So we published this, and one of the replies we got from the reviewer at a journal in America who speaks English said that there's no bias in pain scores. Why would you have bias in pain scores? So I think it's shocking to me that people, I mean, he really wrote this on a document sent to us. So I think that all of us hopefully on this call recognize there's going to be bias, be it age, race, whatever. We all have it. We can't get around it. And so asking somebody for pain and do they need pain is really not great. The term that we use in the pain literature is called escape medications. That's also not great because how much opioids you use post-block can be really tough because some people are really naive to opioids. You know, maybe I would need, 4 morphine for the rest of the day, but Joe Brown would need 50. I don't know, right? It just depends on how naive you are, what your deal is. They use noxious stimuli as a subjective endpoint for pain scores. I'm not going to do that. You can do that. Does this hurt? Does this hurt? We did a study. We tried to do a study years ago on serratus anterior plane blocks. And the idea was to do, David's shaking his head because it never took off the ground because of this, because we want to do sensory dermatomal distribution and noxious stimuli, because somebody in our department who's very smart, smarter than me, went through the anesthesia literature and found endpoints from anesthesia world. And nobody wants to do that in the ED. It's just not we don't have the time, we don't have the desire. One of my interns who's on this call wants to do qualitative pain evaluations, which I think is fantastic. This is essentially do a block and then have a qualitative discussion with the patients. It takes a lot of money. It takes time. It's a great idea. And I'm not going to poo-poo it, but I think it's something that's reasonable. So these are all kind of where we are. And I don't think the qualitative pain score is objective, but again, people have different views of pain. So novel endpoints, I can send this article out and I'm going to summarize it. There's a bunch of stuff in the literature and some of the pupillary size they've done, heart rate variability. So it's essentially autonomic changes for pain scores. So does your heart rate change? Does your pupil size change? Do you have piloerection? You can make up so you have more sweat on your skin. There's even these studies where they look at neuromodulators that these skin patches are placing on to look at it. They're doing a ton of stuff on inflammatory markers. Chronic pain, because how do you know somebody has chronic pain? They send off all these weird levels. My center does not have these tools for my pain endpoints. fMRIs, there's a great study that I read this morning on EEGs and machine learning. They slap these EEGs on patients and look at machine learning and see if there's a way to detect if pain is reduced. Great. I don't know if you guys have this, but this is a really interesting thought process to do it. Maybe the Brigham has it. I don't have this. I was hoping that we could talk about from the lens of the ED physician, and really it's block specific endpoints that I want to know about. And there's a term I think you guys may have heard of. Anybody heard the term jobs to be done? This is this kind of those businessy terms. They'll use it in the design world. And I'll read out this quote because I think it'll make sense. When we buy a product, we essentially hire it to help us do a job. If it does the job well, the next time we're confronted with the same job, we tend to hire the product again. The idea being that in the business world, they would say, hey, Joe, do you like A or do you like B? And that to them is subjective. But if you're every time you do a block and you're able to reduce a shoulder, that's jobs to be done, right? Your job was, I need to get the shoulder back in. Can I put the shoulder back in? That's that terminology. They'll call it JTBD. There's all this weird stuff in the business world about this. But the idea being that if we think of it that way, then it's a much more objective causal solution to the problem. I think this is alternatives to procedural sedation, right? If I can do a procedure without procedural sedation, then the job has been done, because I didn't have to subject the patient to procedural sedation, which is risks, and also the time. And I know you guys all work in an ER, getting your charge nurse to move a room and getting end-tidal CO2 and getting respiratory therapy there, all that garbage really is a pain in the butt. And really the downstream endpoints is what I care about. I'm gonna talk about two papers really quickly because I think they do a really good job of this. So this is a paper that's pretty old, maybe a few years out, 6 years old. This is a really nice study done in New York. I don't know if Srikar's on the study, I don't remember. But they did blocks, they did ED blocks, they had single injection blocks, and then they had catheters placed by anesthesia. And why I like this paper is they looked at pain scores, right? So pain scores went down with femoral nerve block and controls. But again, you can argue this is subjective. They even looked at pain scores 2-3 days out and showed at rest, at transfer, at walking, right? Control groups versus the block group did better. And then what they did, I think was fantastic, was 3 days out, they looked at distance walked and reduction in parental opioids. So again, two endpoints that may be useful at 3 days out, which I think, again, what they're doing is really intelligent to me, is they're thinking about this as a non-subjective endpoint, and they're using some objective endpoints. We did this with this diaphragmatic paper that I actually gave a talk out in Boston, and it was a virtual talk, and Sigmund, he's the second author on this, just like literally raises his hand at the end of it, and he's like, why don't you just think about diaphragmatic excursion? I'm like, holy great, this guy's a genius, right? This is why it's nice to go out into the field.
I mean, Sig's a peds, Sig's PEM. So he actually does this on kids all the time, even before this, not for blocks, but looking for like lung ultrasound.
Yeah,
so this is like totally in his wheelhouse.
But that's exactly right. We have to like cross-pollinate with other people and not just be like, Dave and I are like, we're gonna do a blog, look at pain scores. So we published this, and this one just came out, I think, a few months ago. And this is this group out of, I think it's Turkey, I don't know where they are, but the idea at Egypt, excuse me, they did a study where they did retrospinae and they did serratus for rib fractures and showed retrospinae was better, but also looked at diaphragmatic excursion and showed to be better. They did sham studies, which we don't do it. We try not to do them in Highland just for the IRB aspects, but showed to be efficacious. But again, use diaphragmatic excursion. I think another endpoint that we don't talk about a lot, which is incentive spirometry, right? Are they able to take nice deep breaths? What's the volume of breaths are they able to take? So I think just thinking outside the box on this. And so I think in the ED blocks, right, I just, in my mind, again, jobs to be done, does interscaling functional for shoulder reduction and without procedural sedation? Is supraclavicular brachial plexus block functional for distal radius fracture reduction without the need for procedural sedation, right? The transgluteal sciatic nerve block study that Andrew put together with Nicole, and you can talk about this, the endpoints are pain, and what else, Nicole?
So pain, ambulation, so functional status. So how long does it take you to get up and walk to a certain point and back? Do you feel like you can walk? So I mean, still kind of subjective, right? Like if I push them out of bed, they're probably going to stand, but it's like, it's still subjective, but at least it's something more than just rating scales.
Right, and it's an endpoint, because if I can get my patient to walk out of the ED, right, we all high five. So I know it may not be the great endpoint for the anesthesiologist, but for me, it's a great endpoint. And then I go back to that cancer patient pain. Imagine if we did blocks on people and the patients who, I mean, if, one of my intern, where's Henry? But Henry looked up the data on this and what percentage of patients who come in for cancer pain get admitted for pain control. And if we were able to block those people and give them some pain control to last in the morning where they can start oral therapy or even start their oral therapy in the ED, those would be endpoints that I care about. So I'd love to hear from everybody else on what they think would be a good, sorry, I'm gonna stop sharing, what you guys think will be great endpoints for pain, because if we include this in our studies, one, we do it from the lens of the ED physician, and two, I think we'd publish much more interesting stuff, because I don't want to repeat anesthesia studies, not because they're not doing good studies, it's because that's not our endpoints. Our endpoints are not the OR. Our endpoints aren't subjective dermatomal distribution. I really don't care about dermatomal distribution. It's nice, but I care about if the patient can do X, Y, and Z, or I don't need to do X, Y, and Z to them. Any thoughts?
I mean, I guess
I
one
can
thing.
just give you.
Oh, sorry. Go for it, Nicole.
Go ahead. No, I can just give you examples of what we've actually done here. And I think it
Good.
just varies greatly as to what you're using the block for. So we've had a couple of odd examples too, where we've done tap blocks for umbilical hernia reductions, and we're able to avoid procedural sedation. So endpoint such as just avoidance of procedural sedation for a procedure that typically requires a full moderate sedation, a nurse at the bedside, and the whole kit and caboodle, I think is actually a great endpoint. We're actually using that for our nitrous study, where we're looking at shoulders going in with nitrous versus procedural sedation. So we've now used blocks for other random indications. Sorry, I'm like in the middle of a shift. I'm trying to see what else is coming at me. Where are the EKGs? But we've done hernia reductions using single shot regional anesthesia, and we are now looking at publishing a case series of using fascia LIACA blocks for femoral traction pens without the full procedural sedation too. And we have 3 cases of each.
Yeah.
So I think just in
that's great.
general, avoidance of the procedural sedation is an appealing endpoint.
That's right.
And
So I
it's
think
kind of a negative endpoint, but
that's one endpoint, but I think we can even think about more, right? I think that's the one we've classically leveraged at Highland when it came to all our, humerus fractures, all of our abscesses. It's always been like, do we need to do procedural sedation? And the paper we just sent off to Annals, that was one of our endpoints. I think it's a soft endpoint because somebody can say, again, I don't mean that in a bad way. I think I've done this, is I can do procedural sedation. You're just going to yell a little more. I'll get your shoulder in, right? So there are other things I think we can even test, and I just don't know them. And I would love to hear other people's thoughts on what they like and what they've tested or tried. And Joe and Nicole had some comments.
I was just gonna. My first point was just I think starting with what's the indication for doing the block in the first place. If it's pain control, if the goal is to discharge, if the goal is to reduce opioid equivalents. We've kind of talked about all of these things a little bit separately, but I think initially linking it with what's the true endpoint, like what's the goal and why are we doing it in the first place is probably the first branch.
Right. So it's the jobs to be done. And that's how, the way I think of it. Like, what's the job to be done for the block? And if we define that and then we use that as our endpoint, it just can be tricky, right? Because using FAST exam, right? There's the famous story of Melniker, right? The FAST exam looked at time to OR. The problem with that is my surgeon just takes everybody to the OR real quickly. And then there's always that one trauma surgeon is like sitting there picking his or her nose for 20 minutes and be like, can we get another blood pressure? And you're like, dude, take the patient to the damn OR. So I think that endpoint to me is an endpoint, but it's still subjective. I'd like even more granular endpoints. I'm gonna look at the chat while I'm gonna hear Nicole. I'm gonna hear your thoughts.
You actually gave me this idea just now, Arun. I've got a headband, a monitor, a mobile EEG headband that we're using for competency metrics, but it actually can also measure biophysiometric data like sweat index, heart rate, things like that. We usually pair it with a wristband. So, I mean, I don't know how well it's proven for pain specifically because it's usually for like altered levels of consciousness and things like this. But I bet you could find like either a correlation study or you could just do a really quick like study of pain in the ED and get a really quick baseline and then start comparing your block studies to that. But I like looking at like actual objective data, like the biophysiometric things. And so there are newer devices that are out there that make it much more reasonable in the ED instead of actually having to put on a full EEG apparatus. Like you can use things like these surrogate markers. So I don't know, that might be something to look at.
Even heart rate variability, right? I was just looking at this morning, heart rate variability may be a really good marker. We all get vital signs every 5 minutes on all our patients post blocks. And so seeing heart rates come down significantly, seeing blood pressure decrease, I mean, that's an autonomic theory. So that could be good. I mean, it's obviously biased by people who have high blood pressure intrinsically, people are on stimulants, whatever, right? But I think that it could be some signal that we should just be recording and thinking about.
I think it depends on what you want to look. If you want to show first that the block is effective, sure, then we can focus on these markers that are going to show more objective data. But then if we want to make it patient-centered, I think we have to think of outcomes that are also clinically relevant to the patient. Do they care that their heart rate is not varying, that it's less, that they're sweating less? Like we got to, actual outcomes. And I think that's where, like, I think that like Henry's thoughts about like patient satisfaction. I mean, like, how many times have I had people get a shoulder back in it? Like I remember the most recent guy I had, he was traumatized because they gave him like a little bit of the water beforehand and pulled on it and it was terrible. we did the block, he was so worried the whole time. It's like, oh my gosh, I'm so anxious. The shoulder went back in. He was like, what? He was just like blown away by how it could have been, done painless and pain-free. So I mean, I think there's two different kind of avenues we have to think about in terms of the study we're looking at.
I don't want to throw the baby out with the bathwater. What I'm trying to say is, and I wanted to put that slide and I forgot to, I think we should still be leveraging pain points, like how much your pain score, opioid use, right? Those are easy things for us to test. And I mean, and David knows this, in our Holland block protocol, they document and then they get that. Those are fine. And I like the subjective things. I just think that when we're thinking of study design, we should also be thinking of other and add more on. So I really like the fact that the back pain study that we did with the transgluteal sciatic, we used walking distance, because it could have easily just been like, let's just use pain. And we could just use this stuff, right? So I think adding on a little bit more objectification allows us to publish more and more solid publications.
Arun, quick question. Maybe I missed this. It looks like you were looking for something more besides the pain score, and like trying to prove we don't have to do procedural sedation. You're looking for some other objective endpoints. I guess besides what you just said, we can publish more. What are we trying to prove by having other endpoints? Is there anything else? Maybe I missed it. You already said it.
Well, I think that comes down to that jobs to be done thought process, right? Like, why is Joe Brown doing a tap on the patient? Well, because I want to do a reduction of the hernia, right? Or I want to do no opioid use for the shoulder abscess, or no procedural sedation. So I think that's one of the points. And I think that we have to think about it. The reason we looked at diaphragm was because it's an easy test for us, right? I've blocked numerous people, and David points this out, and they're like, the block's not working. And I'm like, wait, you have rib fractures, the block's not working? No, it's not working. I have no pain control. And if I look at their diaphragm is moving dramatically. So before and after, it's moving, 2 centimeters, and afterwards moving 5 centimeters. So that gives me more of an objective marker of the job to be done, which is reduction in, right, getting pneumonias post fractures or whatever. Do you understand my point, Shrikar?
Yeah, I feel like you want like more evidence. Actually, the block is working.
Right.
More objective markers. Is that correct?
That's exactly right. I want real. I think I'm not saying to throw the baby out with the bathwater. I think that I'm going to use pain control. I'm going to use opioid equivalents. I'm going to use all that stuff. But I think as a group, what's nice is if we all group think this, somebody will be like, oh, how about this for this block? That's a great point. Let's do it, right? So I think if we group think this, I think we'll get to more endpoints that I think are very valid, and actually will change the way that the ED physician thinks about blocks, rather than just leveraging the anesthesia endpoints.
So Arun, just to separate this, there are two ways to look at it. There are benefits, right? Length of stay and all that stuff. That's not what this discussion is about. This is more about an objective marker saying that the block is successful. Is that correct?
Right. If I had, N-glutathione that I could draw before and after, and the N-glutathione level was elevated, and I did your block, and then the N-glutathione level fell down, I would love that, right? And there's all these articles that talk about these physiological biomarkers they're looking at. I'm not going to be doing that. It's really hard to do that. Length of stay is interesting, right? But it's really hard because at Highland, when I discharge somebody, 2 hours later, the nurse gets around to discharging them. And David's smiling because I know which nurse he's talking about. So it's a really hard endpoint for me. I don't work when I was at Rhode Island Hospital, you discharge somebody, they go. So yes, Shrikar, so that's what I mean. Does that help you, or does that clarify it, or am I still confusing you?
No, that's good, because the challenge is now it has to be something which can be done quickly at bedside, and it cannot be expensive, but it has to be objective, right?
That's right.
All right.
Right. So like I was saying, the shoulder reduction, no procedural sedation is a great endpoint. That's a fantastic endpoint rather than pain control, because the guy maybe just like, I want some opioids when I'm done. All the procedural sedations, like Kat pointed out, is a nice solid endpoint. I think we can think about more like this as a group. We'll actually get better data and better studies.
Just wanted to chime in too. I think one of the points of doing a qualitative research project would be to look at like having lots of open-ended questions to see if patients could also help us determine this. Like, are there objective things that patients experience that would overall be clinically meaningful to us. And I think that's why like having much more open-ended conversations with them could possibly lead to a more objective outpoint.
Yeah, I think that's what you want to do here, Henry. And I think that's gonna be great when you set it up. Again, it's a ton of work, right? You need research assistants, you need 30 minutes of time. I can't be doing this because I did the block. It is definitely it's a higher workload for hospital centers. I think ideally, if you're grant funded, it's a little bit easier. So I think it's a really interesting idea. I don't know the answer to this. I wish I had a perfect answer. I would be doing these studies. And that's why we published that diaphragmatic excursion study. It was because you want to push the limits of what we could think about. I like the wearable bracelets, the sweat index. I spent way too much time reading that literature. I was like, it's all over the place. But it is interesting. The pain people are really trying to find objective markers. And they're not very successful, but they have a lot of funding to do this because they obviously want to not propagate opioid dependence. So especially in chronic pain patients.
But I also bet in the ED, like acute pain, like an acute trauma pain is going to be a lot different than like a chronic pain patient. So I'm wondering if we could just kind of reset those standards by like doing a few like baseline pilot studies and just see if there's any correlation for like a certain type of injury or something, right? Like I bet you somebody who's been living with their back pain or their sciatica for years and they're in like an outpatient clinic is going to be a lot different than somebody who feels like they can't walk, you know?
Yeah. I think you could easily do this with just heart rate variability with femur fractures or hip fractures and see if that makes a difference. It's hard if the patient's on beta blockers or other stuff, but if they're non-medicated, it'd be an interesting, at least just case series it could do. The spirometry stuff is fantastic. That's what good studies are doing. We're going to be doing that with all of our serratus anterior and erector spinae blocks for fractures. That's one pathway, but I think there's more out there that we're just not picking up. For hips, I just don't have a good endpoint.
Yeah, I was gonna say, I think the other challenge that we run into is kind of the age-old, like if we're saying procedural sedation or not as our endpoint, there are still so many of the old dogs that are just like, well, I can do procedural sedation, I know how to do all the meds, and I'm in and out. And so I think that is one of those where utilizing, I mean, it stinks, but I mean, the thing that speaks to most ER providers at this point is length of stay in terms of the boarding problem is so bad that even though you hit discharge and maybe it takes a while at your institution, but like that's like kind of the primary currency at this point, I think, for most docs, whether or not they're doing them or not. And I think that is one of those where if you could, for the sciatica pain that you're doing a transgluteal sciatic nerve block, if you're like, you don't have to put this person in OBS to CPT to do whatever, and you can prove that the length of stay is decreased and the functional outcomes are quicker, I think that's where length of stay does become kind of a golden ticket that makes this more desirable, I guess, for someone that's not doing them to start trying to pick them up.
Yeah. No, I totally agree. And again, this is a paper that came out of the San Diego group. I talked to them. They're actually talking to us. And they want to build a multi-center study using D5 normal saline. And the idea being that the theory is that for the transgluteal sciatic, you're compressing the sciatic nerve and you're just opening the space up. So I think there is, there's a lot of ways that we got to push it and think outside the box and not just follow anesthesia. I think that we could really do something really cool and really get it to a point where it is just the way that we practice emergency medicine. And so I like all these ideas. And if people have ideas, we should pass them around and think about ways to look at endpoints rather than the way that I've classically looked at endpoints, which is just pain and opioids. And then try to leverage all of our block studies with something more objective. Or as Henry would say, more subjective. But you understand the point, Henry. That's it. And we have any more questions, comments, thoughts?
It might be interesting if we have data already. We could look at all of our shoulder dislocations and kind of do a retrospective analysis of all the ones that receive blocks versus procedural sedation versus nothing, I guess, and see length of stay. But there's so many confounding variables. I mean, I know, like, especially at Highland, we're terrible in terms of everything, but there might be some sort of, trend that we could observe potentially.
Yeah.
I think the downside there is that if you really want to convince other people to do this, you got to kind of translate this to a single operator ED model, which is most of the EDs in the US, right? Like when you're working at Kaiser by yourself, like, can you actually do this as a single operator and not have an ultrasound team that's coming by to block the patient, right?
Yeah. So I do agree. I think these are all interesting things to think about. I'm just kind of throwing it out there, that everybody, hopefully, if people have thought, we should all just kind of talk about it. Emails go back and forth. I think there's some interesting ideas that people are putting in the chat. I mean, for us, return rate would be tough because our patients explode into the ether once they leave the ER, and they come back for 18 other things. So that would be tough for us. But again, in a Kaiser model, I think this would be really interesting. They have, the beauty of Kaiser or Intermountain, they have all the rats in their maze at all times. And so they can really follow these people. I think it would be really fascinating to do it there. I just don't think they have the people who are pushing the field and doing blocks in their institutions. Anyway, I think that's good for me. Anybody want to round out the last one? Anybody have any thoughts for the next meeting? So we've done frank neuroparalysis with brachial plexus blocks. We've done femoral nerve blocks, kind of the basic nomenclature. We've done block endpoints. Just again, the idea is not to have a lecture. The idea is just to have a conversation. Post block monitoring, that's great. I'm happy to do that. You guys okay with that? We can talk about what the data is on that, what anesthesia is doing, and even maybe you can add in monitoring and discharge, because that's something that we all hopefully are discharging people with blocks. And are you letting them go home and resting their elbow on the stove? Yeah. How to get faculty to do blocks. It's a great question. Yep. Adjunct. So yeah, so I'm gonna actually pass this on. If somebody wants to raise their hand and do maybe post block monitoring or discharge, do you want to do that, Joe? Okay. So I'll let you send the email. You have the email for the group. I'm trying to pass the buck purposely because I don't want to hear myself talk anymore. I'd rather have somebody else do all this. But if Joe wants to do that, we can go forward. Evan, I can maybe talk to you on the side about how to get around your orthopedics. Yeah, either Joe or Dan, if you guys want to do that. I know Joe's running a post block discharge instruction pathway, so you guys could do it together. I'm okay with that. But we can talk about, you want to set it up and you guys have a Zoom link. I say we go for it. Is everybody good? Next date, pick a date. I try to do, let's say Monday. Today's Tuesday. So I try to do Mondays at around 2 o'clock or 3 o'clock because it kind of allows people to finish their shifts in the East Coast. But there's nothing set in stone. Once a month, probably the end of the month is probably better. I'll let you guys run with it. Yeah, so probably discharge, Andrew. Discharge or post-block monitoring. I think you do that together. Anything else? Any other comments?
That sounds great.
Yes.
Joe, let me know if you need help at all.
Yeah.
But this was an awesome conversation, Arun. Just listening while working, brainstorming endpoints, because I think you're totally right. Our next step to prove that ED can do this and do it well and have superior results is to do good research. And it's not subjective pain scores, unfortunately. It's what Joe said earlier, which is what our goal to discharge or goal of block is. It's so important to think like that instead of just thinking pain scores the entire time.
Yep. No, I totally agree. I don't think we should throw the baby out the bathwater. I think you're going to have pain scores, which is fine. Ideally, Arun doesn't do the block and walk over and go, "Ma'am, how's your pain?" She's like, "Great, you're a nice doctor." I mean, obviously we have more intelligence than that, but the point being that using that plus an endpoint is where we need to go as a field.
Totally. But it's also thinking like our pain counterparts who do chronic research on this, whether it's opioid equivalents or what do they care about, and making sure that's included when we do pain scores.
That's right. That is correct. I couldn't agree anymore. Anyway, 30 minutes. I'm 5 minutes past your time. You guys all have more interesting lives than listening to me. And thank you, Shrikar, for joining. Did he leave already? Yeah,
he's out.
That piece of crap. He was on for 5 minutes. I'm going to text him and be like, what an ass. Anyway, thank you guys. Enjoy the day, guys. Everybody have a good day.
See ya. Awesome. Thanks so much, man.